have no idea about who the lead lab is. What all it said that. You don't have to list the people.
Again, on the screen,
Ganesh Raman.
நீங்க எப்படி சார் உங்களுக்கு
Drop taxi. Drop taxi.
ஓகே
Only one day.
கேன்சல் பண்ணீங்க எங்க கூட வந்துருங்க யாரு ஓ
ஒட்டியில் 3 இருக்கும்
என்ன கம்பெனி சொல்லுது
ட்ராப் டாக்ஸி
பேர்
ஃபர்ஸ்ட் டைம் இப்போ கேள்விப்படுறேன் பேரே ட்ராப் டாக்ஸி
ஒன் டே போனோம்னா நான் முடிஞ்சு
டிஃப்ரெண்ட் ஆப் இருக்கு அதுக்கு
ட்ராப் டாக்ஸி
ஓசோ கேப்னு ஒன்று இருக்கு அது நல்லா இருக்கும் இது நல்லா இருக்கு
சிங்கிள்
அதான் சிங்கிள் இது சென்னைக்காக தான் அங்கேருந்து கோஆர்டினேட் பண்ணுறோம் இட்ஸ் நாட் ஆப் ஃபோன் ஆப் இருக்கு ஆப் இப்போ ட்ராப் டாக்ஸி ஆமாம் கேள்விப்பட்டிருக்கேன் அப்படியா
ஒன்வேனா கொஞ்சம் நம்ம இப்போ 10 rupees ஆகிட்டு 10 rupees
அது
இல்லைன்னா
இந்தியா ஒன்றும் சைக்கிளாக கொடுங்க
10 plus 20 வாங்குவோம்
ரீசனபிளாக இருந்தால் ஒன்றும் பிரச்சனை இல்லை
நீங்கள் வந்து கேள்வி தான் கேட்கணும் ஹலோ ரெடி ஓகே
மார்க் போட்டுட்டு போயிட்டு அதே நான் பார்த்தது தான் பார்த்தது
2 நாளாக முடிச்சு ஃபைனல்
பெஸ்ட் ஆஃப் 6 பெஸ்ட் ஆஃப் 1
8 ஸ்டூடெண்ட்
6 ஸ்டூடெண்ட் இருக்கு
ஒரு செஷன்ஸில் வந்து ட்ரைனிங்
Dr. Jayalakshmi. You come to, or you want to call?
Yeah, call, because I don't have it.
Okay.
I like to use it.
Dr. Teresa, Dr. Lisbeth, Dr. Apsara, Karu, Dr. Remy, Dr. Julie, Dr. Brenda, everybody's there. Okay, start there. Everybody is there. No, that's all. So, shall we start then? You'll have to call the names. I don't have the list. So, yeah.
So the first speaker on the podium is Dr. Jayalakshmi, who will be talking to us on our paper FP5, Effect of Mydriatic on Octa Parameters in Diabetics and Controls.
Good afternoon all. My paper is on the effect of mydriatic, that is tropicamide and phenylephrine on OCT angiography parameters in diabetics and controls. Introduction. An OCT angiogram is usually done on a patient in mydriatic state, and the drug commonly used to dilate the pupil is 0.8% tropicamide and 5% phenylephrine. Tropicamide is a benzene acetamide, which is a parasympatholytic agent which blocks the M4 muscarinic acetylcholine receptor. Phenylephrine is an alpha-1 adrenergic receptor agonist that induces vasoconstrictive activity. Both these drugs were found to have an effect on retinal capillary perfusion. A drug-induced change in the vascular status of the macula has not been established unequivocally. Aims and objectives: the pre and post mydriatic foveal avascular zone area, vessel density and perfusion of the macula was compared between three groups of patients. First one, normal subjects. Second one, diabetics without retinopathy, and 3, diabetics with retinopathy. 16 normal subjects were included in the study, 37 patients without diabetic retinopathy, and 8 patients with retinopathy. Materials and methods. Inclusion criteria included all patients who visited ophthalmology OPD and were willing for dilated fundus examination and an OCT angiography. Exclusion criteria included center involving macular edema, history of glaucoma, history of VR surgery, refractive error more than 6 diopter, any condition impairing the media clarity which prevents good quality OCT imaging like opacities, corneal opacities, uveitis, dense cataract, vitreous hemorrhage, and non-diabetic macular pathology. This is a cross-sectional observational study. A total of 61 eyes were enrolled, out of which 45 eyes were of diabetic patients, of which 37 had no diabetic retinopathy and 8 had diabetic retinopathy, and 16 eyes were of healthy controls. After standard ophthalmic examination, OCT angiography 3x3 was taken before and after dilatation using HD Cyrus OCT 500/5000. The parameters compared were the foveal avascular zone area and vessel density and perfusion of the center, inner and full areas. Moving on to statistical analysis, the software used was SPSS MAC version 22.0. Changes in the FAZ vessel density perfusion were tested using paired t-test. Stratified analysis was done for those with and without diabetes. The diabetics were further stratified as those with and without retinopathy. Statistical significance was defined as p-value less than 0.05. Moving on to results. 35 eyes of females were included in the study and 26 male eyes, and there were 34 right eyes and 27 left eyes, and the diabetic status 37, that is 82%, had no diabetic retinopathy. 3 eyes had mild NPDR, 4 eyes with moderate NPDR, 1 eye with severe NPDR, and no eyes were included with PDR. Moving on to vessel density. So among the 3 groups, before and after dilatation, a statistically significant increase in vessel density was noticed in the last group, that is in diabetics with retinopathy. Similar results were also seen in vessel perfusion, where a statistically significant increase after dilatation were observed in diabetes with retinopathy in the center and full area. In foveal avascular zone also, an increase in foveal avascular zone area was noted in diabetes with retinopathy after dilatation. But here in FAZ area, the value was not statistically significant. Moving on to discussion, a statistically significant increase in vessel density and perfusion after administering the drug were noticed in the macular vasculature of eyes with diabetic retinopathy. Significant interruption of blood retinal barrier, excess in diabetes at the vascular endothelium. This can increase the intraretinal concentration of the mydriatic that is applied. Tropicamide is a drug that has maximum transport across the cornea. It can theoretically abort acetylcholine activity in pericytes. Thus, it can limit the contracting ability of pericytes and keep the vascular wall relatively dilated. And phenylephrine acts mainly on the alpha-1 receptors, and capillaries of the macula has got alpha-2 receptors. Therefore, phenylephrine cannot exert activity at the macula. And in the study, along the preservative in the mydriatic was chlorbutal, and it is known to have it is known to weaken the contractile response of the vascular smooth muscle. This could also be an added factor in increasing the perfusion of macular vessels with defective blood retinal barrier, as noted earlier. Then, as the principle of OCT is based on broadband light source, flicker-induced over-response in the anatomically and functionally compromised retinal vessels also may be considered. Conclusive note, OCT and OCT angiography are commonly employed standard investigative procedures in diabetics and retinal clinics. On the basis of our findings, we would suggest that these tests are preferably done undilated, if at all possible, for a better delineation of macular vasculature if an underlying pathology is present. Thank you.
Thank you. Next on the podium, FP17, Dr. Teresa. Ocular manifestations in patients with psoriasis attending a tertiary healthcare center.
Good morning. My presentation is on ocular manifestations in patients with psoriasis attending a tertiary healthcare center. Introducing, psoriasis is a systemic condition affecting 1 to 3% of the world's population. It's a chronic inflammatory disease affecting the skin. The pathogenesis is immunocellular dysfunction and inflammation. It manifests as erythematous and squamous plaques. Ocular manifestations in psoriasis can be due to direct or indirect mechanisms. Direct mechanisms include eye involvement with psoriatic plaques, and indirect mechanisms include immune-mediated inflammatory response. Aim and objective: early detection of ocular manifestations observed in patients with newly diagnosed psoriasis and to detect and report any changes in retina using OCT. Materials and methods. Study design: it was a cross-sectional study. Study setting: in the Department of Ophthalmology and Dermatology in a tertiary healthcare center. Sample size: it was 50 patients with newly diagnosed psoriasis. Those patients who had signed the informed consent and those obtaining high quality OCT images, that is signal strength 6 out of 10, were included in the study. And those patients who had history of ocular trauma, ocular surgery, or with Stevens-Johnson syndrome were excluded from the study. Method of data collection: 50 patients with newly diagnosed psoriasis were selected. Detailed history and examination were done, and OCT, macula, and RNFL were recorded. Coming to results, out of the study sample, 54% were males and 46% females. 32% of the people had visual impairment, and 68% were vision was normal. The ocular manifestations found were dry eye, keratoconjunctivitis, blepharitis, uveitis, episcleritis, and cataract. The corresponding percentage of these manifestations were dry eye 40%, keratoconjunctivitis 30%, blepharitis 14%, uveitis 12%, episcleritis 8%, and cataract 20%. The mean IOP among the study sample was 14.26 mm mercury. Mean photostress recovery time was 19.15 seconds. Mean RNFL thickness was 92.54 microns, and mean central macular thickness was 258.90 microns, which were all within normal limits. Coming to discussion. Psoriasis, being an immune-mediated disorder, affects the lacrimal and meibomian glands, thus causing dry eye, which is the most common ocular finding. In psoriasis, normal irid flora is disrupted, leading to overgrowth of staphylococcal species, thus causing blepharitis. In psoriasis, pro-inflammatory cytokines are increased, like TNF-alpha and IL-6, which increases oxidative stress, leading to secondary cataract formation. Coming to some similar previous studies, Kalia et al. In the study, Ocular Manifestations in Moderate to Severe Psoriasis in India, a prospective observational study conducted in 2022, concluded that most common ocular pathologies observed in the study were anterior blepharitis and moderate dry eye. Cosby et al. In the study Psoriasis and Uveitis, conducted in 2022, concluded that relation between non-arthritic psoriasis and uveitis have not been fully elucidated. Physicians who treat this disease must be cautious and refer their patients to the ophthalmologist even if they do not have any symptoms. Concluding the study, psoriasis have several ocular manifestations even at the start of the disease, many of which leads to visual impairment as well, such as uveitis, keratitis, and cataract. Most of these are curable, and further complications like corneal ulcerations due to severe dry eye can be prevented by early detection. Hence, patients with psoriasis should undergo regular eye examination regardless of risk factors to monitor for progression of ocular manifestations. These are my references. Thank you.
Thank you. Okay, thank you. Next, I'll call upon Dr. Lisbeth to present her paper.
Good afternoon. Profile and determinants of macular ganglion cell inner plexiform layer thickness in South Indians. Ganglion cells, being the final output neurons of retina, are essential for maintaining vision, and thinning of this crucial layer is seen in many neurological diseases like multiple sclerosis, Alzheimer's, Parkinson's disease, and also in glaucoma. But there's a wide variability of normal thickness among these studies, and there are limited studies, especially in South India and Kerala. So the aim of this study was to find out the normative data and determinants of macular ganglion cell inner plexiform layer thickness in South Indian population, and the objectives were to find out the normative data of patients attending OP in a tertiary care and to find the association of various demographic as well as selected lifestyle and neurogenic risk factors with this thickness. This was a cross-sectional hospital-based study done in ophthalmology OP of a tertiary care center spanning over a period of 1.5 years, and the sample size calculated was 168. Those who were included were aged more than 18 years with best cortical visual acuity of 20/20 with refraction within plus or minus 5 diopter sphere and plus or minus 2 diopter cylinder. And those who were excluded were systemic and neurological diseases that might affect the retinal architecture, ocular disorders like glaucoma or ongoing inflammations, previous intraocular surgeries or laser treatment, any factors affecting the OCT signal strength like media opacity or non-dilating pupil. After obtaining informed consent, demographic data was collected and systemic history including diabetes, hypertension, history of smoking, alcoholism, and digital screen time were recorded. Visual acuity and anterior segment was evaluated. IOP was measured using Goldman applanation tonometry. Fundus was visualized after dilating. OCT macula was taken by a spectral domain OCT, and using the ganglion cell analysis program, the distance between the inner border of GCL and outer border of IPL was measured. Coming to the result, of the 168 sample, 55% were female, and the median age of the sample was 47.5 years, and majority, 26% were less than 30 years. 40% were diabetic and 21% were hypertensive. 6% were smokers and 22% consumed alcohol, and majority had a screen time of the range of 2 to 5 hours. The mean GCL IPL thickness from this study was 79.49 plus or minus 6.373 microns, and the males had a slightly higher of 79.79. Females had 3.86 times odds of having GCL IPL thickness below 80. GCL IPL thickness found to be significantly decreasing with age, with patients above 47.5 years having 13.5 times odds of having GCL IPL thickness less than 80. And negative correlation was noted between GCL IPL thickness and age, with a decrease of 0.151 micron per decade of life. Significant thickening was seen in diabetics and hypertensives, and diabetics had 2.72 times odds of having GCL IPL thickness less than 80. And negative correlation was noted between duration of diabetes and GCL thickness, but it was not statistically significant. This data where a 60-year-old female who is diabetic and hypertensive for 10 years has a severe thinning of GCL IPL thickness, comparing with a 25-year-old male with no comorbidities. Significant difference in GCL IPL thickness was noted according to digital screen time, with thinning in patients with screen time more than 10 hours. Smoking and alcohol consumption also caused thinning, but it was not statistically significant. Discussion. Normative data obtained from our study was 79.49, and from the parent study of Mansa et al. It was 82.1, and Sundaram et al. And Indian study was 84.04. Insignificant thinning was seen in diabetics, similar to other studies by Shoki et al. And Pekal et al. And hypertensives also had a significantly thin GCL IPL thickness, similar to Lee et al. And Nam et al. To conclude, average GCL IPL thickness from this study was 79.49 plus or minus 6.3 microns. Age, female sex, diabetes, hypertension, digital screen time were found to be the determinants. What's the clinical implication of this study is, this study provides a reliable reference normative data of the South Indian population, especially of Kerala. And in diabetes and hypertension, GCL IPL thinning preceded fundus and OCT signs of retinal microvasculopathy, which has great implications in retinopathy screening. And to our knowledge, this is the first study in which digital screen time has emerged as a possible modifiable determinant of retinal neurodegeneration. What is the scope? Association of GCL IPL thickness and digital screen time need to be studied further with proper history of the type of device being used, any blue filter was used, distance from the device, quality and make of the device should also be considered. These were my references and thank you.
Thank you. Next I'll call upon Dr. Apsara to present her paper on retinal capillary macroaneurysm diabetic macular edema.
Good afternoon all. Our paper is on retinal capillary macroaneurysm in chronic diabetic macular edema, response to various treatment modalities. Diabetic maculopathy is most common cause of visual impairment in diabetic patients. The chronic diabetic macular edema is defined as macular edema persisting for more than 6 months without any treatment or more than or equal to 6 months even with anti-VEGF therapy. We all know that microaneurysms are most common and initial finding in diabetic retinopathy with a size smaller than 100 microns. The large aneurysmal dilatation of retinal capillaries are called retinal capillary macroaneurysm or RCMA with a size ranging from 100 to 300 microns which leaks and cause refractory macular edema. This study is to assess the efficacy of various treatment modalities for retinal capillary macroaneurysm in chronic diabetic macular edema with respect to visual acuity, central foveal thickness and size of retinal capillary macroaneurysm. It is a prospective study conducted in 50 eyes of 39 patients from January 2023 to March 2024. The patients with RCMA in diabetic macular edema treated with either intravitreal pharmacotherapy, either anti-VEGF or dexamethasone implant with or without focal laser photocoagulation. The patients were assigned to different treatment based on their response to any previous treatment and location of macroaneurysm, whether it is center involving or not. The macroaneurysm within 500 microns of foveal center are excluded from focal laser. The retreatment was given in case of recurrence of edema during follow-up and the injections were given on PRN basis. The data analyzed are logMAR visual acuity, central foveal thickness in microns and size of retinal capillary macroaneurysm in microns at baseline, 3 months and 6 months. The central foveal thickness and size of RCMA were measured using manual caliper tool in STOCT Heidelberg Spectralis. The study group include RCMA of size greater than 100 microns and located within the arcade. Both treatment naive and newly treated patients were included. The aneurysm of size smaller than 100 microns and those present at or beyond arcade were excluded and other retinal vascular diseases were excluded. In our study, 80% of the patient received intravitreal pharmacotherapy, out of which 54 patients received pharmacotherapy alone and 46 received focal laser with or without pharmacotherapy. Average number of anti-VEGF received during the study period is 2.06 and dexamethasone implant was 1.16. And 36% of the study group had single RCMA and 64% had multiple RCMA. At the end of 6 months, the visual acuity stabilized in all groups except anti-VEGF monotherapy group. Similarly as visual acuity, the central foveal thickness reduced in all groups except anti-VEGF monotherapy group. The RCMA size responds very minimal with anti-VEGF monotherapy and it responds well when laser alone or in combination with pharmacotherapy given. This is the pre and post treatment picture. The second picture showing regression of RCMA following direct focal laser. This is pre and post treatment picture. The second picture showing resolution of edema and involution of RCMA following intravitreal dexamethasone and focal laser. Our study is the largest study on RCMA in chronic diabetic macular edema and we also compared the response of various treatment modalities including the combination therapy of focal laser with intravitreal pharmacotherapy and we documented the good response of laser with respect to stabilization of visual acuity and macular edema. According to Spade et al., the rapid resolution of edema and involution of aneurysm was shown with laser. Spade et al. Found that RCMA is an important biomarker in diabetic retinopathy which may not respond to intravitreal anti-VEGF and steroid and respond well to focal laser. Sagar et al. Showed that the DME secondary to large capillary aneurysm respond well to targeted laser. Pakis et al. Showed that the chronic DME refractory to anti-VEGF had better anatomical and functional outcome following focal laser. Thus, we conclude that detecting retinal capillary macroaneurysm in chronic diabetic macular edema is essential for customizing treatment approaches in patients. The retinal capillary macroaneurysm show poor response to anti-VEGF therapy whereas it responds well to targeted focal laser. However, only less than 50% of the lesions are amenable to focal laser because of its proximity to fovea. So, in remaining 50% lesion, the intravitreal dexamethasone implant is better option than anti-VEGF. We also found that diabetic macular edema secondary to RCMA also shows sustained response to combination therapy of focal laser with intravitreal pharmacotherapy. These are my references. Thank you.
Thank you. Next, I call upon Dr. Swaroop KS to present his paper on knowledge, attitude, practice pattern regarding medical legal aspects among cataract surgery patients.
Good afternoon all. The topic for my paper is knowledge, attitude and practice pattern regarding medical legal aspects among cataract surgery patients. These are my contents. As we all know, medical legal aspects have gained significant attention in the past few years. There are about 5.2 million cases of medical error filed in India every year, and the number has increased by around 400% in the last decade. However, the knowledge, attitude and practice regarding this aspect remains poorly understood, and cataract surgeries are often advertised as no pain, no stitch procedures done often as daycare basis with immediate vision gain, increasing the patient's expectations, leading to ophthalmologists being more vulnerable to such litigations. So my objective was to estimate the knowledge, attitude and practice pattern regarding medical legal aspects among patients posted for cataract surgery. So it was a hospital-based descriptive study conducted among 52 patients posted for cataract surgery after obtaining their informed written consent. Patient demographics and past history of surgery was collected, and the questionnaire had 3 parts, namely knowledge, attitude and practice with 5 questions each. Knowledge was based on the prior knowledge the patient had regarding the importance and need for consent and other medical legal aspects. Attitude was regarding the attitude towards the need for knowing about the treatment and its complications, and other aspects like patient's responsibilities, rights and responsible behavior. Practice was based on what the patient had done regarding consent, patient's rights and responsibilities following his or her admission. Responses were recorded and scores were given, and based on the total score, the patients were classified as having good, average and poor knowledge, attitude and practice. Statistical analysis was conducted using the SPSS version 24, and p-value less than 0.05 was considered as statistically significant. The results showed that the mean age among 52 patients was 66.9 plus or minus 9.4 years, and majority of them, that is 65%, were females. 83% belonged to below poverty level and 52% had past history of surgery. Coming to education levels, we can see that 60% had completed their primary education and 8% were illiterates. Now, as you can see in the graph, 21% of the patients showed a good knowledge level, average knowledge level was seen in 48%, and poor knowledge level was seen in 31%. 92.3% of our patients knew that informed consent was not merely a formality and is of legal importance, while none of our patients was sure that they had the right to withdraw the consent if required after signing it. Statistically significant relationships were found between knowledge level and education as well as knowledge level and age. Attitude results were promising, as 81% showed a good attitude, while only 19% showed average attitude. 86.5% of our patients were of the attitude that they had to maintain decorum within the hospital, and only 44.2% felt that it was important to read the patient responsibility guidelines given by the hospital. Significant relationships were found between attitude and education level as well as attitude and history of surgery. Practice levels were concerning, as only 2% showed good practice patterns, 46% showed average practice patterns, while the majority, that is 52%, showed poor practice patterns. 78.8% had inquired about all aspects of surgery along with its complications, while only 1.9%, that is 1 out of these 52 patients, had read through the patient's rights and responsibility guidelines displayed in the hospital. Significant relationships were found between practice level and age, practice level and education, as well as practice level and history of surgery. As you can see in the scatter plot, there was a moderate positive correlation between knowledge and attitude scores, a strong positive correlation between knowledge and practice scores, as well as a strong positive correlation between attitude and practice scores, all three of which were statistically significant. So in my study, it was found that knowledge was good in 21%, average in 48%, and poor in 31.2%, similar to the results obtained by Garima Kachava et al. 92.3% of our participants knew that informed consent was of legal importance, which was much better than the results obtained by a study conducted by Sanjay Marasani et al. It was concerning to note that 53.8% believed that they could not withdraw their consent after signing it, similar to the results obtained by Rajesh Dr et al. This study also showed a positive association between level of education and knowledge as was seen in our study. Despite the average levels of knowledge, 80.8% showed a good attitude, which was better than the results obtained by Felix Embanera et al. This study also showed a moderate positive correlation between knowledge and attitude, similar to the results obtained by our study. Despite average knowledge and good attitude in majority of our patients, only 1.9% showed good practice patterns. This might be the reason for the increased number of violence and unnecessary allegations against doctors, as was highlighted by the 2015 survey by the Indian Medical Association, showing that 75% of doctors have faced some form of violence throughout their career at work. So my suggestions include using visual aids, informative videos, simplified language and repeated explanations as suggested by the work of Abrar Karan et al. And Anita and Shukla et al. Awareness programs can be conducted among the public as well as the medical staff, and medical legal aspects with their practical applications can be made a part of the curriculum. The limitations of my study include it can be conducted with a larger sample size, it can be conducted among the general public as well as the medical staff to assess their awareness. So my study highlights the interconnected nature of knowledge, attitude and practice in the context of medical legal aspects of cataract surgery. Although Kerala boasts the highest literacy rate, the good knowledge and attitude were not translating into practice. And my study also shows the influence of social demographic factors on knowledge, attitude and practice. Hence, providing targeted educational interventions at the grassroots level is essential in bringing about a significant change in the society. These are my references. Thank you.
Thank you, Doctor. Next, we'll call upon Dr. Remy Salim to present her paper on to correlate clinical features, vision with SD-OCT changes in patients with myelinated nerve fibers.
Good afternoon, everyone. My topic is to correlate clinical features, vision and SD-OCT changes in patients with myelinated retinal nerve fibers. MRNF, it is a benign congenital anomaly in which the RNFL anterior to the lamina cribrosa have myelin sheath. It is a defect in the lamina cribrosa which allows the oligodendrocytes to gain access to retina. It is seen in up to 1% of population, and 7% of the affected patients have bilateral involvement. Clinically, it appears as white striated patches at upper and lower poles of optic disc. It is an irregular fan-shaped in appearance. The OCT shows hyperreflective RNFL. The aim of the study is to correlate clinical features vision with SD-OCT changes in patients with MRNF. It is a retrospective study of all the patients with MRNF from January 2015 to October 2022. Inclusion criteria is with all the patients with MRNF with documented fundus and SD-OCT images. The data collected included the age, gender, visual acuity, refraction, slit lamp examination, anterior segment, posterior segment, laterality, quadrant, and macula involved. Also, the investigations were fundus photo and SD-OCT. The results among the 26 patients, the age group were between 11 months to 75 years. And in the gender, the majority of them, 18% of the 18 patients were male and 8 patients were female. Laterality, 20 patients showed unilateral involvement and 6 patients showed a bilateral involvement. Visual acuity. Average visual acuity in eyes with MRNF was 1.1 logmar, that is Snellen 672. Range of visual acuity in eyes with MRNF was 6.6 to counting finger at 1 meters. Average spherical equivalence in patients with MRNF in the right eye was -5 diopter sphere and the left eye was -2 diopter sphere. Range of spherical equivalence in eyes with MRNF was -12 spherical equivalence to +0.25 spherical equivalence. Refractive error in MRNF is most of the patients were myopes among the study group. Among 26 patients, 22 patients were myopes and 4 patients were hypermetropes. Amblyopia in MNF, among 12 amblyopes, all were myopes. And among 12 amblyopes, 4 patients exhibited Strathmore syndrome, which is unilateral or bilateral MRNF with axial myopia and amblyopia. And 1 patient had reverse Strathmore syndrome, that is unilateral MRNF, hyperopia, and amblyopia. Among 12 amblyopes with MRNF, 6 patients had extensive MRNF, which is 4-quadrant involving and posterior pole. 1 patient had exotropia with MRNF involving the posterior pole. 9 patients had anisometropic amblyopia. Anterior segment examination. 22 patients were within normal limit. 2 patients had cataractous changes in the lens. 2 had strabismus, which is esotropia and exotropia respectively. Posterior segment quadrant and macula involved. The OCT finding for all the patients with MRNF had retinal nerve fiber thickening, in which 6 patients had all 4 quadrant and posterior pole involved, 8 patients had equal to and more than 2 quadrant involved, and 12 patients had less than 2 quadrant involved. OCT findings. In case 1, in which is a 14-year-old female with BCV of right eye is counting finger at 2 meters and left eye with 6 is vision, with normal anterior segment findings, in which the OD fundus shows extensive MNF all along the arcades. The OCT shows that there is a RNFL thickening and hyperreflectivity, and the inner retinal structures could not be visible. Case 2, it is a 21-year-old female with a BCV of right eye 660. Anterior segment findings are normal, fundus showing myelinated retinal nerve fibers invading the posterior pole, and OCT shows RNFL hyperreflectivity and altered inner retinal structure. A 32-year-old male who had a BCV of right eye 6.6 and left eye of 6.9 with normal anterior segment findings, fundus showing OS extensive MNF all along the arcades. The OCT shows RNFL hyperreflectivity and altered inner retinal structure. This retrospective study reports the visual outcome of patients with MRNF depending on the quadrant involvement, macular involvement, and OCT finding. The impact of MRNF on visual acuity is highly variable and depends on the extent of myelination patches or if the macula is involved. Optic nerve abnormalities such as dysplasia, hypoplasia can be coexistent. In this study, 26 patients with MRNF, 6 patients had 4-quadrant involvement, had vision ranging from counting finger 1 to 160, 3 with macula involved had vision ranging from 660 to counting finger 1. 12 patients were amblyopic, in which amblyopia due to anisometropia were given proper glasses and patching, and strabismic amblyopia were also managed with eye patching glasses or eye muscle surgery. Our observation was that despite adequate optical and amblyopia therapy, those with 4-quadrant and macula involved did not improve in their vision, proves the fact that amblyopia is not entirely anisometropic but also due to sensory deprivation due to structural alteration in retina. Conclusion: MNF involving all arcades and macula involved have a greater impact on visual outcome compared to less involved cases. These are my references. Thank you.
Thank you. Thank you, doctor. Next, I'll call upon Dr. Julie Anthony to present her paper on SMART trial, smartphone assisted retinoscopy trial.
Good afternoon to all. My topic of presentation is gimbal scope, SMART trial, smartphone assisted retinoscopy trial. So as we all know, retinoscopy is an objective method to assess refractive error. So as a resident in the initial learning phase, it is very difficult for the resident to understand the art of retinoscopy. It is a skill dependent technique, and there is no live demonstration can be done. So usually the mentor teaches the trainee with the help of a schematic model or model eye, and there is no video library available. So usually it's difficult for the mentee to understand what the reflexes are. So usually the mentor teaches the trainee with the help of the cartoon figures or schematic models what the reflexes looks like. This is showing the with the movement reflex, and this is how the against the movement reflex looks like. So that's how the thought of making a gimbal scope came in. So gimbal scope, the smartphone can be attached to a gimbal, and then the retinoscope can be attached. So this is the final look of the gimbal scope. The materials needed for making the gimbal scope are 3 smartphone adapters, any smartphone or Android phone, a retinoscope, and these smartphone adapters can be attached with a simple super glue or rubber band. This is the video showing how to make gimbal scope. The adapters are attached together with a screw, then the retinoscope is placed, and then the smartphone can be attached. The peak hole of the retinoscope should be aligned with the camera of the smartphone. So this is the video recorded using a gimbal scope. You can clearly see the with movement reflex. You can see the against movement reflex and the neutralization point. We have also recorded a patient with keratoconus showing scissoring reflex. So the objectives of our study are to evaluate precision and dependability of smartphone based retinoscopic reflexes and measurements compared to streak retinoscopy and autorefractometer. We have also compared the quality and lucidity of retinoscopic reflexes, time taken and ease of doing. Sample size, we have conducted a prospective comparative study with 1000 cases. Mean age group was selected as 18 to 50 who presented at a hospital for ophthalmic evaluation. The study period was 8 months from November 2023 to June 2024. Methods, 1000 patients were randomly selected. After taking proper written consent, each patient went through gold standard retinoscopy, smartphone based retinoscopy, and the respective values were recorded and compared with values obtained from autorefractometer. Both mydriatic and non-mydriatic readings were taken. Spherical and cylindrical values were also obtained using all three devices. The results obtained were, out of the 1000 cases, there were 532 males and 468 females. And in the undilated patients, when we compare gimbal scope with streak retinoscopy, 823 patient had similar reflexes. There is no difference in the values. Comparing gimbal scope with autorefractometer, 816 patient had similar values. In dilated gimbal scope with comparing with streak, 858 patient had similar values, and with autorefractometer, 874 patients had similar values. We have also measured the accuracy and confidence interval. Overall, all the comparing gimbal scope with streak as well as autorefractometer, we have got the accuracy level more than 80%. So we conclude smartphone based retinoscopy yields refractive error measurements comparable to standard retinoscopy and autorefractometer with no statistically significant difference. It demonstrated feasibility in assessing refractive errors, providing accurate and precise results while minimizing time and discomfort. So it is an excellent teaching tool. You can do it by yourself. It is very economical and cheap. You can do live demonstration. You can also record the reflexes and use for any presentation or future discussions. It is a very affordable toolkit for any ophthalmology resident, and you can also use this zoom option if the reflexes are not clear, maintaining the same working distance. As any other tool, our gimbal scope has limitations. There is an initial learning curve in assembling the gimbal scope. Due to the smartphone, as the smartphone is attached, there is an added weight. There is minor differences in measurements, and there is a difficulty in accessing the focusing sleeve. These are my references. Thank you.
I just have a question. When you were doing the videography with trying to neutralize the reflex, so was there any difference in capturing the images, in the quality of the images which you captured while without any trial lens, whatever is the neutralization thing, whether they're using a cylindrical lens or a spherical lens in front of that? Did you find any difference in the images?
No, ma'am. No change in the quality of the reflex.
Oh, quality of the images. You were able to capture same quality of images with the trial lens in place?
Yes, yes. With any change in the smartphone?
No, not the smartphone. The focusing distance and all. Did you have to vary that or something? Was that a part of the learning curve you had?
No, same working distance. You can get the reflex.
Thank you. Next, I will call upon Dr. Brinda to present a paper on E-log atlas, a timeless reflection of postgraduate life.
Good afternoon, everyone. I'm going to present on E-log atlas, a timeless reflection of PG life. A logbook is an integral part of PG residency because it helps in a structured learning, and it helps a PG resident to document our clinical as well as surgical milestone. It encourages our responsibility, and it helps us how much we have to improve where we are lacking. It improves professionalism, and a logbook can be used for evidence of certification and portfolio for future exams. For a mentor, it can be used to assess how much their mentee is improving and where they have to train them, and it ensures competency. For years, we have been following a written logbook, but with a written logbook, there is legibility issues and it is prone for human errors. There is risk of loss because there is no option for a backup, and storage is also limited with a written logbook. To find a case in a written logbook is difficult as there is no option for search. So inconvenient to update because when we update it become more messy. There is a limitation of maintaining high quality images. It is difficult to share. We have to present physically to share it. And there is lack of integration. Ophthalmology heavily relies on visual diagnostic, and for an ophthalmic resident, it is really crucial to interpret and remember the images we are seeing in order to develop a strong diagnostic skill and clinical decision making. So that is how we attempted to revamp the traditional logbook approach by encompassing more clinical photograph along with a concise summary of interesting cases we see in OPD as well as community outreach program. We collected images from the same in 10 months of our first year residency. Initially, we used to collect images using our smartphone. We even tried to collect series of images of the patient during their follow-up visit also. Later, once we were okay with the slit lamp, we tried to collect images we have taken with the slit lamp, which is attached with an imaging system. So with the slit lamp which were not attached with an imaging system or especially in the peripheral center, we used small smartphone adapters to attach with the slit lamp and take the images. In fundus photograph, we collected from the fundus imaging system in our hospital, and for community outreach program, we used 3D printed anterior segment photo imaging system to take the anterior segment photographs, and for posterior segment we used smartphone based 3D printed posterior segment imaging system as well as smartphone based portable fundus cameras to collect the posterior segment images. Later, we used to discuss with our consultant regarding the images, and we used to collect the short summary of the cases, and we documented it into simple digital platforms like MS PowerPoint. Later, we added annotation to the images to improve the quality of the images so that it will be more helpful for us in future. I would like to request you to look into few pages of our eLog Atlas we have created. On process, we used to collect images even from the operation theater, and we cooperated with the lab we are attached with, and we used to collect the pathological images also and add annotation to the pathological images also. Later on, when the images were increasing, we divided it into specialty wise, into anterior segment as well as the posterior segment. So changing from a written logbook to e-logbook has improved efficient data entry because the fields were customizable and there was an option for automatic backup, and it can be secured with password also. There is an option for search, so it was easier to find for a case, and it was more flexible and easy to update. It was easier for sharing, and remote access were also possible. And multimedia integration were also possible. It improved our accuracy of logbook and standardized the documentation. This is the e-logbook we follow now. And adding images to our logbook, that is creating an e-log atlas, has enhanced our visual learning. It encouraged our active learning and reflection. Always image stays in our brain better than a text. So it improved our retention and recall. It enhanced the learning of disease management, and it supported our collaborative learning because we used to share the images as well as summary and details in the WhatsApp group so that everyone will be benefited from that. And it aided us as a potential tool in the OSKs and Vivas, and it helped to integrate technology in medical education. That is, we can either add hyperlink of the video, surgical videos also with the logbook, and it can be protected also with password. And it facilitated the mentor for objective assessment and virtual feedback. To conclude, eLog Atlas stands as a cherished, timeless reflection of our postgraduate life by beautifully merging the precision of a logbook with the richness of Atlas. So we can adapt this eLog Atlas in our PG resident curriculum also. This is my references. Thank you.
Thank you. Any questions? Thank you. And I think we have come to the conclusion of the evaluating the papers finally. So I think it's been a great pleasure to be here, part of KSOS. And I not only congratulate all the people who presented, I also congratulate their mentors I think we have very good teachers and mentors to guide all the presenters for this, free paper sessions and even the other sessions. It's been a wonderful experience for us. I think we'll just submit the documents and we can get the result from the scientific committee. Thank you very much.
Thank you, dear judges and presenters. Wishing you all the best.
I think I really had a great experience here, and in fact, I learned a lot. Okay, thank you very much.